Hello, everyone. I am Professor Radu Vladareanu, and on behalf of the Romanian Society of Obstetrics and Gynecology, it's my honor to be part of on this event. I believe that my presence in the event will not only serve as a testament to the progress and development of our country, but also as a symbol of our commitment to international cooperation and collaboration to fight preeclampsia. I look forward to meeting and engaging with individuals from different parts of the world and learning from their experience and perspectives. And it is my sincere hope that through this event we can improve our practice for the better care of our patients. For the past 20 years, the focus on prenatal screening program has been for the fetal Down syndrome, or trisomy 21. The prevalence of preeclampsia and related conditions as fetal growth restriction and preterm birth is much higher than Down syndrome, as you can see. Furthermore, unlike Down syndrome, preeclampsia is a major cause of maternal and perinatal morbidity and mortality. So, preventing preeclampsia would bring substantial improvements to the maternal and perinatal health. Here is NIS latest updates that included and recommended Delphia Express PLG-fit testing with values for both standalone and ratio results, also being the only test to perform all trimester screening as standalone marker to reduce the cost. Modeling shows that all these tests are cost-effective compared with standard assessment when used to help diagnose, to rule in or exclude, to rule out preterm preeclampsia. So these tests are recommended to help plan safe care and save both births for people with preeclampsia and also to identify people unlikely to develop preeclampsia and therefore reduce unnecessary hospitalization. The tests may work differently in people who are pregnant with more than one baby, of course. Therefore, NIS has recommended further research to find out how well the tests work in this group. The ASPRE screening algorithm, you all know about that, for the same screen positive rate as per NIS, National Institute for Health and Care Excellence, identifies 75% of cases of preterm preeclampsia. It identifies a group of at-risk women that responds to aspirin in the prevention of preterm preeclampsia. Fetal Medicine Foundation, led by Professor Nicolaides and his team, after several years of research with many data on ultrasound and biochemistry markers, have finally come to an updated algorithm that includes the basis of NIS guidelines, but updates it with the Doppler pulsatility index and biochemistry tests. So the most effective algorithm that was chosen for the ASPRE study screening part was the triple test. So meaning mean arterial pressure, uterine index pulsatility index, and placental growth factor. This triple test has been proven to give a high detection rate for preeclampsia before 37 weeks at 77% with 10% false positive ratio. FIGO guidelines have strong position for preeclampsia because it's one of the leading causes of maternal mortality and morbidity in the world. So worldwide, about 2 to 5% of pregnant women are affected by preeclampsia starting from 20th week of pregnancy. As you can see, the maternal mortality in Europe and in different countries like England, Nordic countries, and Romania. Romania has a very direct percentage, high percentage of direct cause to 72%. It's very, very high comparing with England, that is half of it. 1 in 6 maternal deaths worldwide are due to preeclampsia, as a matter of fact. Nowadays, pregnant women expect doctors to offer effective prenatal care based on the latest research evidence, screening, and preventive solutions. They want to receive the best clinical care possible through the pregnancy. With regard to preeclampsia, we are stepping into a new era in terms of how the disease is predicted and managed. The ASPRE study has now given definitive evidence that the best way to reduce the rate of preterm preeclampsia is through early prediction and prevention by low-dose aspirin. A significant 62% reduction in the rate of preterm preeclampsia among women who would otherwise develop the condition is great news for women at risk and their families. This is a part of our guideline. It's of course in Romania for preeclampsia. We consider also a standard the blood pressure. Diagnosis is not unfortunately yet considered by placental growth factor. Of course, it needed an update. This update will come in the next weeks because we know that PLGF is one of the most predictive markers of preeclampsia development. We already have in our guidelines of preeclampsia the prediction and prevention with aspirin, and here are the details. Method of predicting preeclampsia based on clinical factors has a modest positive predictive value, just blood pressure measurement. The detection rate is only 37% for early preeclampsia. And of course, we should find the place for PLGF in high risk factors for a better prediction that will be done shortly. This is the model of combined preeclampsia screening. It's made up of 4 simple steps and require a very short training. As you see, we record the medical history. It's very important, the weight and height. Take a blood sample and measuring placental growth factor, first, second, third trimester, plus minus PPI. We measure the blood pressure 2 times from both arms simultaneously with validated automated blood pressure devices. And of course, we measure the uterine artery Doppler pulsatility index by transabdominal ultrasound. Timing, it's important. Critical for the efficient prevention in high-risk pregnancy is the dose of 150 milligrams of aspirin, starting ideally at week 12, before week 16 at least. We should take this at bedtime. The patient should take this at bedtime, stop at 36 weeks. And we should know that it's not effective after 16 weeks of pregnancy, this strategy. If no screening has been done in the second trimester, PLGF can be used as aid in diagnosis of preeclampsia as a standalone marker further to the updated NICE guidelines. The objectives of the COMPARE study, as you know, is to evaluate the performance of placental growth factor-based test in predicting delivery within 40 days from testing in women with suspected preterm preeclampsia before 35 weeks gestation. So, of course, we should update immediately our national guidelines to include the PLGF marker, standard laboratory test for diagnosis, as single marker or by ratio with SFLT1. Currently, these are not yet mentioned in the 2019 Romanian guidelines. And of course, the PLG3 low values must be considered and included in the high-risk factors. Thank you for your attention, and we'll look forward to the next presentation.